Hi everyone, my name is Caroline Pete, and today I will be talking about the mechanism of action of vasopressin. Vasopressin, also known as antidiuretic hormone, is a nonapeptide hormone that is synthesized in the hypothalamus and released into the circulation in the posterior pituitary gland. So here you can see an image of the hypothalamus. So there's the hypothalamus, and then right here is where the posterior pituitary is. Vasopressin plays a significant role in helping the blood vessels constrict and allowing the kidneys to control the amount of water and salt in the body, ultimately assisting in the control of blood pressure and the amount of urine made. The hypothalamus produces vasopressin and then secretes it into the blood via the pituitary gland. So, getting into more details of the development of vasopressin, it is derived from the prohormone called prepropresopresophysin. This preprohormone contains a single peptide, neurophysin 2, in glycoprotein. In the Golgi apparatus, the signal peptide portion is cleaved from the prepresophysin to produce a prohormone stored in the secretory vesicles. As it travels to the posterior pituitary, where vasopressin is released, the prohormone is cleaved to produce vasopressin. There are neurons that have their cell bodies in a supraoptic nuclei of the hypothalamus and are mainly responsible for the production of this hormone. There are also neurons with cell bodies located in the paraventricular nuclei, also known as the main site responsible for oxytocin, that contributes to the production of vasopressin in smaller quantities. Storage vesicles are then sent down the neuron's axon via hypothalamic hypophyseal tract and are released in the posterior pituitary. The secreted hormones enter the body's systemic circulation through nearby fenestrated capillaries. So right here, we have a nice visual representation of this process. So here you can see on the right is the oxytocin that we talked about. And then over here is the ADH or vasopressin. So you have the prepropresophysin, and then through the cleavage of the signal peptide and packing in vesicles, you get prepresophysin, and then the cleavage of neurophysins and axoplasmic flow takes place right here. And then you have ADH and MP2. And then this gives you ADH, which is made and sent through the kidney and blood vessels. As we previously touched on, vasopressin is primarily responsible for tonicity homeostasis. The neurons that store this hormone express osmoreceptors that are very responsive to blood osmolarity, causing secretion of vasopressin to be initiated by even the slightest elevations in osmolarity. Vasopressin returns the osmolarity to baseline as it increases water reabsorption in the kidneys. Secretion can also be initiated during states of volume depletion as there are decreased baroreceptors that sense arterial blood volume in the left atrium, carotid artery, and aortic arch. When these receptors sense low blood pressure, they transmit this information to the vagus nerve, which stimulates the release of vasopressin. As it is released, water reabsorption in the kidneys is promoted, resulting in vasoconstriction. The two mechanisms combined cause an increase in effective arterial blood volume in blood pressure to maintain tissue perfusion. While various factors contribute to the stimulation of vasopressin secretion, such as angiotensin II, pain, nausea, hypoglycemia, nicotine, opiates, and certain medications, there are two significant stimulating factors known as osmolarity and volume status. Additionally, ethanol serves as a factor that negatively affects the secretion of vasopressin. This is because ethanol can cause increased diuresis and increased free water loss, resulting in more water being excreted by the kidneys if there is not sufficient vasopressin secretion. This image right here provides a good visual of factors that stimulate and inhibit release of vasopressin from the posterior pituitary. So right here you have the stimulate release, and then right here you have inhibits release. And then right here you can see a little asterisk next to norepinephrine. And that's present because it can stimulate the release by A1 receptors and inhibit release by stimulation of A2 and beta receptors. The effects of vasopressin are employed by binding to the kidney's principal cells found in the late distal tubule and collecting ducts. Vasopressin binds to the V receptor of these cells, activating adenylate cyclase, resulting in an increase in the second messenger cyclic AMP, also known as CAMP, CAMP. Protein kinase A is activated by CAMP, which initiates an intracellular phosphorylation cascade. AQP2, a water channel that is responsible for promoting reabsorption of water in the kidney, is phosphorylated, allowing the body to conserve water in the event of dehydration or loss of sufficient blood volume. In this image, you can see a model of the regulation of water permeability in renal collecting ducts. So you can see the binding of vasopressin, known as AVP, to the V2 receptor right here in the basolateral membrane, which then activates the adenylate cyclase right here, where you see AC. And then after this, you can see that protein kinase A, also labeled as PKA, is activated, inducing a translocation of AQP2, bearing vesicles to the apical membrane. And then you can also see that CAMP right here activates the exchange protein, which increases systolic calcium and ultimately facilitates translocation of AQP2. And then the activity of PDE can be controlled by EPAC by inhibiting ERK5 right here, which also then inhibits PDE. And then you can see here that PKA also increases the AQP2 synthesis by inhibiting extracellular signal-related kinases 1 and 2. And then water can enter the cell by, so here's the little guide here. So you have AQP2 as the dark blue, AQP3 as the yellow, and then AQP4 as the green. So the cell enters with AQP2 and then it leaves with the AQP3 and AQP4. Vasopressin also has a large effect on vascular smooth muscle. In this case, vasopressin binds to the V receptors on the vascular smooth muscle, activating the G protein, which then activates phospholipase C, resulting in the production of inositol triphosphate and diacylglycerol. This causes the signaling phosphorylation cascade to occur, leading to an increase in blood pressure. This mechanism, in addition to water reabsorption, elevates blood pressure. When there is insufficient arterial blood volume, this mechanism is important to the maintenance of tissue perfusion. Clinically, vasopressin is commonly used in the form of injection to help with various conditions. Patients with diabetes insipidus experience major dehydration, so this injection can be used to control frequent urination, increased thirst, and loss of water associated with this condition. Additionally, it can also be used post-surgery to prevent and treat abdominal or stomach distension. Lastly, a vasopressin injection can be used to increase blood pressure in adults with vasodilatory shock if they still have low blood pressure after receiving fluids and other medications. In relation to this clinical significance, I found an interesting study about the use of vasopressin injections in dogs. This study mainly analyzes the mechanism of vasopressin-induced bradycardia in dogs. Bradycardia is a condition where the heart is beating abnormally slow. During this study, the cardiovascular effects of vasopressin injection were examined in order to determine whether there was a central component of the cardiovascular action of vasopressin. The vasopressin was injected in the cerebral ventricles of dogs to investigate this. It was hypothesized if bradycardia is present after an IV injection of vasopressin, then it can be associated as a result of a peripheral depressant action on the heart. And if bradycardia is present after a lateral or fourth ventricle injection, then it can be accounted for by a central stimulating action on the cardioinhibitory neurons in the region of the vagal nuclei. In the conduction of this experiment, 47 dogs, a mixture of both males and females, were used as test subjects. Their weights ranged from 8 to 16 kilograms. Each dog was anesthetized by intravenous injection of chlorelose, with the dose ranging from 80 to 100 milligrams per kilograms, depending on the dog's weight and gender. They were maintained on intermittent positive pressure ventilation in efforts to prevent the effects of alterations in respiration on the cardiovascular system. The vagi high in the neck was cut and the cervical cord was transected at C2 in order to study the efferent path of vasopressin-induced bradycardia while preventing the rise of systemic arterial pressure induced by intravenous vasopressin and so eliminate the reflex effects of baroreceptor stimulation on the cardioregulatory neurons. A mercury manometer and smoked chemograph paper were used to record the arterial blood pressure from the left femoral artery. The heart rate was determined from lead 2 of the electrocardiogram, and the mechanical buffer system was used to stabilize the blood pressure. The routes of vasopressin injection include the lateral ventricle, fourth ventricle, and intravenous. The volume of the injection of vasopressin did not exceed 0.25 milliliters, and only one dose was administered to each dog. An overview of the experimental results is displayed in this figure right here. So we have table 1. You can see that the state of the dog is listed right here on this side. And then you have the vasopressin, the number of vasopressin units, the injection route, the number of experiments, the maximum change in blood pressure, and then the maximum decrease in heart rate. So some things to keep in mind when reading this table. When the number of experiments is less than 5, so you can see like right here, the range is going to be provided in parentheses. Also, where you see none under the vasopressin units, this indicates that 0.25 milliliters of saline was injected as a control. Through this experiment, it was found that there was a rise in arterial blood pressure and slowing of the heart caused by the intravenous injection of 2 units of vasopressin. The rise started 20 seconds after the injection, peaked around 2 minutes, and gradually went back down to the pre-injection level after around 30 minutes. Bradycardia, or slowing of the heart rate, began within 30 seconds, peaked at around 5 minutes, and lasted over 30 minutes. The mean maximal increase in the arterial blood pressure was 24 millimeters Hg, and then the mean decrease in heart rate was 48 beats per minute. When using the buffer device to stabilize the arterial blood pressure, an IV injection of 2 units of vasopressin only caused a small rise in blood pressure. However, there is still evidence of a slowed heartbeat displayed by the mean maximal decrease of 36 beats per minute. The injection of 0.25 milliliters of saline into the lateral ventricle did not show a significant rise in the arterial blood pressure and showed mild bradycardia at 6 beats per minute lasting around 15 minutes, as seen in the table provided. The injection of 1 unit of vasopressin into the lateral ventricle caused a slightly greater rise in arterial blood pressure, but caused definite bradycardia, although still less than the IV injections. Bradycardia started within 40 seconds of the injection and lasted around 30 to 90 minutes. The bradycardia was not affected by stabilizing the blood pressure. The mean maximal decrease in heart rate was 31 beats per minute. So in this table, you can also see right here, the spinal cord transection was not as effective as bilateral vagotomy in reducing the bradycardia that resulted from the vasopressin injection into the lateral ventricle. After cord transection, the injections produced a mean maximal decrease in the heart rate of 17 beats per minute, whereas the vagotomy results show 8 beats per minute. After the vagotomy plus cord transection, the mean maximal decrease in the heart rate caused by the vasopressin injections was 2 beats per minute. You can also see that the 1 unit vasopressin injections into the fourth ventricle had almost no effect on the arterial blood pressure. However, it did cause bradycardia. This began within 10 seconds of the injection, which was earlier than after an injection of the same dose in a lateral ventricle. The bradycardia hit its peak around 15 minutes and lasted for about 90 minutes. The mean maximal decrease in the heart rate was 39 beats per minute and was 26 beats per minute after the lateral ventricle injection. Minimal bradycardia was produced post-bilateral vagotomy. And so here we have figure 1. So this figure displays the mean change in heart rate. The difference between the effect on heart rate with or without the vagi cut is shown. So looking at the normal and vagotomized results, you can see that the bilateral vagotomy greatly reduced the effect on the heart rate from an intraventricular injection of 1 unit of vasopressin. The time course of bradycardia produced in dogs by an injection of 1 unit of vasopressin into a lateral ventricle is shown. The mean decrease in heartbeats per minute with standard area in 18 normal and 10 vagotomized dogs was determined. So right here, for reference, you have the results here of the vagotomized dogs, and then here you have the normal. So you can kind of see the difference in these two. And then here we have our figure 2. It was determined that the injections did not produce antidiuresis, which indicates that the cardiovascular effects produced by the injections of vasopressin into the lateral ventricle were not due to leakage of vasopressin into the circulation. This was found by measuring the effect on urine volume. On the contrary, a diuretic response was displayed. So this figure right here, you can see the diuretic effect of an injection of 1 unit of vasopressin into the lateral ventricle of dogs. There was a mean, so you can see as it increases up here, and there was a mean increase in urine output with a standard error in 9 dogs. Ultimately, the proposed hypothesis was supported by the experimental results. The results show that different sites of action are responsible for the bradycardia caused by vasopressin injection intravenously and into the cerebral ventricles. The biggest mechanism for bradycardia post-IV injection was found to be myocardial depression as a result of coronary constriction and vagal inhibition as a result of an increase in arterial blood pressure. This was discovered through a comparison of the cardiac effect caused by the same dose injected intravenously under different conditions. For example, in normal dogs, the mean decrease in heart rate after injection was 48 beats per minute, and it was only 36 beats per minute with the use of a stabilizing device, and 30 beats per minute when the vagi were cut. However, when the cervical cord was transected, there was no additional reduction. Vagal inhibition contributed to a decrease in 18 beats per minute, and arterial blood pressure contributed to the 12 beats per minute. In contrast, the bradycardia caused by the lateral or fourth ventricle injection of vasopressin can be accounted for by a central stimulating action on the cardioinhibitory neurons reached by the vasopressin when penetrating the walls of the cerebral ventricles. This was determined after examination of the effects of the bradycardia by stabilizing the arterial blood pressure, cutting the vagi, and transecting the cervical cord. Thank you for listening.